thrilled to introduce to you Dr. Cheryl Bushnell. She's on our COMPASS team. We've been telling you over the past month that she was going to be making our webinar presentation this afternoon, talking with us about the cognitive aspects of stroke. And she speaks nationally and internationally, so we are very fortunate to have her with us and live this afternoon. So I want to tell you just a little bit about Dr. Bushnell. She completed her neurology residency, training, stroke research fellowship, and graduate degree, all in clinical research at Duke University. And after 6 years on faculty at Duke, she joined the neurology faculty here at Wake Forest Baptist in October of 2007, and we're just delighted about that. She was the Associate Director of the Women's Health Center of Excellence until October of 2010, when she was appointed the Director of our Stroke Center here at Wake Forest Baptist. And she led the Stroke Center to Joint Commission certification as a comprehensive stroke center in March of 2013. Her clinical practice is focused on inpatient and outpatient stroke treatment across the continuum, and she has always maintained a strong research interest in women's issues related to stroke. Examples include sex differences in subclinical vascular disease in midlife, cerebral vasomotor reactivity in women with severe preeclampsia, and a new registry to study maternal and newborn stroke. She chaired the American Heart Association Writing Group for the first ever guidelines for the prevention of stroke in women, which received high-profile media coverage such as the front page of Washington Post and NBC Nightly News. She's the co-PI of our study, of the COMPASS study, and she is working with all 41 of our hospitals across the state of North Carolina. So again, we welcome you, Dr. Bushnell, and I am going to momentarily here turn the presentation controls over to you.
Thanks everyone for joining, and I hope that you find this useful. I know this was a topic that many of you wanted to hear more about, and so I'm happy to try and share with you what I know. I'll just say right up front that this is an area that is really devoid of a lot of really good evidence. And so some of what I'm going to tell you about is kind of my own pearls after 20 years of doing this, and hopefully that will be still useful. And I'll try to show you evidence where we have it. So the objectives for today are to just discuss a little bit about the cognitive aftermath of stroke, which I'm sure many of you experience as you're seeing these patients in clinic. Some of the other things we're going to talk about is how to evaluate cognition after stroke, including the timing and which assessments are most useful, and then when to refer for detailed neuropsychological testing. And then I'll finish by talking a little bit about community and work reintegration and some research studies that are ongoing. So starting with the stroke aftermath, there can be a lot of unexpected cognitive deficits that patients experience, and I'll just show you one from a 60-year-old gentleman. Sorry, my page is going off. 60-year-old gentleman who was living in the community, the prominent business member, and he had a stroke that left him with some cognitive deficits that weren't discovered until after he was discharged. And so his direct quote was that after the stroke, I had new prescriptions. I couldn't dispense my medications into daily doses, and this math deficit was not recognized until I got home. I lived alone and I had to take care of myself, and I was unable to cope. So this is just one example, and I know that all of you have seen plenty of other examples just like it. So when you talk about cognitive deficits after a stroke, it's good to just kind of know a little bit about the different lobes of the brain and what the function is for each one. And this is just a very simple colored picture of the brain, and you can see in pink is the frontal lobe, and that's responsible for voluntary movements, personality, emotions, thinking, and speech. In yellow, you have the parietal lobe, which is responsible for understanding language, thought expression, sensation. The temporal lobe is most important for hearing, and then the occipital lobe is most important for vision. So this is a highly simplified graphic showing you with some of the really basic functions of each of these lobes. So it's really important to cover language and cognition together. It's really a lot of patients, 2/3 of stroke survivors, that have these cognitive problems, whether it involves memory, language, or judgment. This is one of the major reasons for the inability to get back to work after a stroke. It has a huge impact on social function. It can be one of the primary reasons that caregivers are increasingly burdened, because they now have to do a lot of the cognitive tasks that their loved one used to do, like writing checks or taking care of the finances, that kind of thing. And one thing that's really important to remember, and therapists know this very well, is that physical recovery and rehabilitation can be much more challenging if there are cognitive deficits, because they cannot remember what they need to do and how they should exercise. And this can make safety an issue as well. And just as, you know, from my own anecdotal experience, my mother has dementia, and it's very, very difficult for somebody with dementia to undergo rehab. So this is a major problem as patients go through their stroke recovery process. Cognitive deficits can have both a psychological and functional impact. There is a lot of relationships and interrelationships between depression and cognition. A stroke can be associated with a lot of anxiety and even a post-traumatic stress type reaction. Other problems include personality changes, the memory that we'll talk about more in detail later. Difficulty with multitasking and slowed processing is a big problem. Impaired problem solving, and then neglect and visual spatial impairment can also be a problem for a lot of the function of these patients after stroke. Starting mostly with the left side of the brain, we know that it causes right-sided weakness, but it's also associated with language and speech clarity. So somebody with the stroke on this side can have aphasia. They're unable to speak, and they could be unable to comprehend any language. Slurring of speech is common. Right face droop is obviously common. And then the inability to organize movement, which is called apraxia. And so I'm not sure if any of your patients have had apraxia, but this is a major problem because they have normal motor movements. But when you ask them to do a set of movements like brush their teeth or get dressed, you can have a lot of difficulty with patients knowing what to do. And this is can be a problem that we call apraxia. Aphasia is obviously quite common, and it's a disorder of language processing that affects speech comprehension, expression, writing, or reading. And it's broken down into 2 or 3 different types. Expressive aphasia is when the patient's comprehension is intact, but they're unable to produce the correct words or sounds, and they're unable to name or repeat. And their speech is non-fluent. In other words, it's broken. It's missing words that put together the usual kind of fluency that we expect with speech. And then there's receptive aphasia, which is a fluent aphasia, and patients are able to produce all kinds of words and sounds, but none of it makes sense, and they can't understand you. And so another name for receptive aphasia is Wernicke's aphasia, which some of you may have heard of. And then for expressive aphasia, it's also called Broca's aphasia. And then the worst kind is global aphasia, and this is usually from a very, very large stroke. And it's the combination of expressive and receptive aphasia. And these patients are mute and they can't understand anything that's being said to them. The prevalence is about 40% of all stroke patients. And within COMPASS, we've been tracking this because we wanted to know how many of our patients would have these communication or cognitive deficits. And it's about 22% of patients based on the enrollment form that you all fill out. The COMPASS eCare data is something that we've been tracking, and we found that there are more patients with cognitive than physical deficits for those patients enrolled in COMPASS and are discharged home. And this table here shows you that 41% of our COMPASS patients had cognitive deficits, and that's compared to 38% or 37.7% that had physical mobility and safety issues. And these were all problems that were flagged by the post-acute functional assessment. And this is from the first 342 patients that had e-care plans. So in other words, it's just incredibly important not to ignore the cognitive issues, although I know that we often will tend to focus on the physical mobility and safety. Remember, the cognitive deficits are key. So can we predict improvement in terms of these language problems or from cognitive deficits after a stroke? That depends a lot on the stroke location. So if it's a cortical stroke, it might be worse than a subcortical stroke. We think of the subcortical structures as being kind of the connection between the cortex and the inner structures of the brain. And so you may have more of a disconnect syndrome with subcortical strokes versus cortical, where it's the primary brain processes that are affected. The size and type of the stroke is important. So hemorrhagic strokes may improve more than ischemic strokes, but the improvement from hemorrhage is typically delayed compared to ischemic. The severity of the initial aphasia is another prognostic factor. So if they are globally aphasic at the beginning, that's a fairly poor prognostic sign. The older the person is, the worse their recovery. This is true for all aspects of stroke deficits, but particularly cognition, especially if patients have had some form of dementia even before they had the stroke. Access to speech therapy can be a factor, and as a lot of you know, the speech therapy that's covered by insurance is often very, very inadequate. It's usually a short period of time, limited number of sessions that are approved by insurance companies. And then neuroplasticity and how the brain is wired is incredibly important. For example, if you have return of blood flow, you might have better recovery, and that's because you restore brain cell metabolism. And then if you have comprehension that deficits, it might recover more quickly than the expressive deficits. If someone has a higher level of education, it may be protective. And if someone is bilingual, often their first language that they learned as a child might recover faster than English if that's their second language. Really, really important that family support and motivation and awareness of the language deficit are taken into consideration with recovery as well. So let's talk about neuroplasticity. The interesting thing is that over the last 10 years or so, we've realized that the brain can actually recover, and neuroplasticity is a property of the brain that allows change of function such as communication between neurons and structure, which is new neurons and connections in response to environmental demands. And so what's interesting is that you can actually have recruitment of brain next to the stroke, and that would be shown in panel A here, with the green area of the brain being the perilesional cortex that can be recruited. And in B, if you have right hemisphere recruitment, that is actually leading to a decrease in left to right inhibition. So the right part of the brain can actually be overriding the left side of the brain at times. And if that is not happening, then you can have more of a benefit from the right side helping the left side. But in C, you have the worst case scenario where the right side is dominant over the left. It's causing inhibition of the left side to have any recovery, and you have this deleterious recovery from language problems. So I'll give you an example of a patient that I've been following for a long time. Her initial stroke occurred about 6 to 7 years ago when she was 49. And she had acute onset of right face and arm greater than leg weakness and a severe expressive aphasia. She had a left middle cerebral artery stroke. She had bilateral common carotid artery occlusions. She was able to understand most language, but she could only say neologisms, which is basically sounds that she made up that made sense to her and was her form of language, but made no sense to the rest of us. She could say 3 or 4 single words outside of her made up words for the first maybe 3 or 4 years. And then gradually, over the 9 years that I've been following her, she can now string together words and is almost completely conversational. She may still substitute yes and no at times, but she has really recovered, and really a delayed recovery over the last 6 years or so. She didn't say much for the first 3 years after her stroke. And I'm showing you now a picture of her MRI scan from 2008. And you can see on the left side of her brain, it's a lot of her language cortex that's been affected in that left MCA infarct territory. And now we do CT-CTA because I'm following her carotid occlusions, and she's got an aneurysm as well. And so now you can see that she's developed these collateral vessels around the cortex, and this is probably helping to recruit some of the territory around the edge of her stroke. She also has a little bit of blood on the inside of her cortex as well. But ultimately, this is all good for her. She's also improving with her hand function, which hadn't it actually kind of corresponded with the improvement in her language as well. So let's talk now a little bit more about the tests that we use to evaluate cognition after stroke. This is the MoCA, and this is considered to be one of the best screening tests for cognition. You can see it's got the trails B in the left upper corner, cube copy, drawing a clock, naming animals, registration of 5 words, digit registration, attention for specific letters, language and repetition, abstraction, delayed recall, and orientation. And so all of that adds up to 30 points total. So MoCA is designed for, it was originally designed for mild cognitive impairment in the elderly, and was developed in Canada, and they're primarily a Caucasian educated population. It's important because it covers the domains that we think are essential for understanding a lot of the stroke deficits. So as I mentioned, visual spatial function, executive function, short-term recall, attention, concentration, working memory, which is the longer-term recall, language, and orientation to time and space. Now, typically, the MoCA is designed, and you'll see this on the worksheet, it's designed with a cutoff score of 26, but this has been tested in stroke patients and is really inadequate. So scores of 19 to 20, 22 in the acute setting might be considered normal for a stroke patient, and then 20 to 27 in the chronic phase is considered normal in the chronic phase. And so this is really important to not give your patients too much grief if they score in that range. And so we need to keep that in mind as we're following patients over time. So obviously there are other alternatives to the MoCA that we could do for screening for cognitive decline, and the MMSE, or the mini mental status exam, is one of them. But we generally prefer the MoCA over the MMSE because MoCA includes executive function, whereas MMSE does not. MoCA has less of a ceiling effect and has more frequently altered items. And basically the MMSE only has a recall of 3 words, very simple, whereas the MoCA has 5. And there's a lot of stuff in between the learning phase for those 5 words in the MoCA compared to the MMSE. So it's a much better test of working memory than the MMSE. And then the MoCA scores are highly predictive of cognitive impairment at 3, 6, and 12 months with almost 90% accuracy. Now, the MMSE is also pretty good at predicting cognitive impairment in the future, but this is just one more reason why the MoCA is a good choice. And then the MoCA has also been associated with functional status based on the modified Rankin score at 3 and 6 months, and that makes sense because the Rankin is telling you that patients can't get back to doing what they were doing before, and so it's not a specific cognitive assessment, but it does take into account the cognitive disability, or a general disability, including cognition, and so that's why it can be helpful for predicting the modified Rankin score as well. So when do you refer to detailed neuropsychological testing and not just rest on your MoCA score? I usually wait at least 3 to 6 months before I consider neuropsych testing, and the reason is that the trajectory of cognitive and language recovery is longer than motor, and so you do need to give people more time. And also, this is around the time that people might be applying for disability, and that's where the formal neuropsych testing might be especially useful. So in my experience, what I've done is refer to neuropsychologists if the patient and caregiver complaints are out of proportion to the bedside cognitive testing. And this would be in somebody with a very high degree of education, high functioning, and the MoCA is just not sensitive enough. And if the patient wishes to return to work and there are concerns about cognitive ability, this would be the time to get a good sense for how they might do. And then if they're applying for disability, a lot of times the application may require it. And then for a lot of our elderly folks, we might be trying to differentiate between post-stroke cognition versus dementia, or another neurodegenerative process such as Alzheimer's disease or Lewy body dementia. And so that's where the detailed neuropsych evaluation comes in handy. So rehabilitation for aphasia and memory is a controversial subject. Of course, speech therapy is essential, and it's focused on a specific type of aphasia, such as naming, finishing phrases or sentences, selecting words to fit a category, and generating words to match a definition. And so that can be one set of strategies to use. And then there can also be compensation for language deficits, and that's where gesturing and drawing come in, but that could also impede language recovery because you're basically working around their language deficit. So very important that you try to work with patients on language specifically and not just workarounds. But for memory, cognitive rehabilitation has been assessed in a Cochrane systematic review as of that was published in 2016. And unfortunately, cognitive rehab really might only provide short-term benefits, but long-term benefits have not been noted, especially for activities of daily living, mood, or quality of life. So this is one of the problems in our current bag of tricks to try to help patients, is that we just don't have adequate rehab techniques for memory specifically. So talking about return to work or driving, and we'll start for this topic is really most relevant for patients who have mild cognitive deficits. And my approach is really highly individualized. This really depends on the patient's deficits and their functional status. Is their modified Rankin just a 1 or a 2, or do they have more severe deficits? And what did they do for a job prior to the stroke? Was it physically or mentally challenging? It's also really important to understand what the work environment is like. So if somebody has hand dysfunction and they were working on an assembly line, then obviously that's something that is going to be a challenge for them to get back to their full-time work. Also, if they are in an environment where their supervisor or their boss is very flexible and willing to work with them, then they might let them come back part-time or just ease into their prior work responsibilities. But a lot of times this is not the case. A lot of employers are just only interested in patients or their employees who can come back and work exactly how they did before. So this is one of the problems with a lot of patients coming back to work. And then if the patient's self-employed, they have a lot of their own flexibility, but you have to be careful, because what if they can't actually cognitively do what they used to do, and they might screw up and they might not be aware of their deficits. So this is another important point, and especially important that the caregiver, spouse, whoever else, business partner, is aware that the patient's had a stroke and may have some cognitive deficits. So my rule of thumb, and this is just, anecdotal, so you can take it or leave it, but I usually tell stroke patients to take 1 month off after a stroke, even if they're doing pretty well. And the reason for that is because of the fatigue that's often worse than the stroke deficits themselves. I also encourage patients to start back part-time rather than full-time, because they set themselves up for huge disappointments and a feeling of failure if they start back full-time and can't do it. And if they clearly can't go back to their previous work because of cognitive deficits, then consider vocational rehabilitation and job retraining or short-term disability. And I can give you an example of a patient that I just saw a few hours ago in clinic today. He's 43. He was in law enforcement, and he did patrol for a small town in Virginia. And he had a stroke from basically a PFO, and he had a small posterior cerebral artery infarct on the left, on the right, that left him with a very small left visual field cut. That's not such a big deal, but over the course of 6 months since this happened, he's had a tremendous problem with cognitive deficits, to the point where his short-term memory is quite poor. He has trouble multitasking. He has slowed reaction time. And this is the kind of guy who could clearly not go back to working with a firearm and doing law enforcement. And so he's tried to look for some jobs and hasn't been able to find anything. He's lost his insurance, and it's a real burden on his family. So even though he had a small stroke and has recovered much of his vision, he is still not back to himself and clearly can't function the way he did before, and he's completely lost his prior line of work. So driving after stroke, again, I usually tell patients to wait at least 1 month, and that will often depend on the type of stroke. And usually patients need to have a doctor or provider clearance before they start driving again. I usually assess the patient's deficits at the time that they come back to see me. You know, do they still have visual or neglect issues? Do they have motor, sensory, coordination problems? Are they still slightly weak on the right side that could affect their ability to use the gas and the brake? Do they have a slowed reaction time? Do they have poor short-term memory or concentration? And, you know, a lot of people don't think that much while they're driving anyway, but there are certainly times when it's helpful to have the ability to solve problems while you're driving. If you're in doubt, you can always get an on-road driving assessment, but those are expensive, and there's only one place in all of North Carolina that does it, and that's Boonville, which is outside of Greensboro. Unless somebody knows of other places, I'm pretty sure this is the only one in North Carolina. And so there is actually a lot of active research going on in the world of driving assessments, particularly with stroke patients. And one particular meta-analysis or systematic review found that if patients take the road sign recognition test, the compass task for visual perceptual and visual spatial abilities and mental speed, and the trails part B, which is part of the MoCA, if they score a certain level on each of those 3 tests, you can get a pretty good idea that they're going to fail the on-road evaluation. And so I gave you the neurology article there that was published in 2011, so you can peruse that for yourself. Now, there has been some review of trials that have focused on rehabilitation techniques for driving, and unfortunately, out of the 4 randomized controlled trials of these rehab interventions to improve driving, none of them showed any benefit for on-road driving. So that's kind of the latest evidence that we have for that. Now, safety issues are things that we think about for moderate to severely cognitively impaired patients with strokes. And I think that this is something that if you don't have the hospital personnel to do is a real big problem, because I think all of these safety issues need to be addressed before they are discharged. So occupational and physical therapy are essential for these kinds of assessments. Your care coordination or case managers may be as well. And so they typically will assess the living environment, their functional status prior to discharge, the caregiver support, their current functional status. And then a lot of times the therapist, as you know, will recommend home health or outpatient therapy. But the home health assessment is really important because they're the ones who are going to be assessing the safety in the home. So we had another case example from the Compass team, and this is a woman who was 41 at the time. She had multiple small infarcts that was of unclear etiology. It was really cryptogenic. She was discharged home. She had Compass follow-up, and this is at the time when we were still testing and refining the e-care plan. So we did the cognitive screening with her on the post-stroke functional assessment, and interestingly, she was actually very articulate in her communication, but with the screening cognitive assessment, she wasn't oriented and she couldn't sequence. So that was a big red flag, and a full MoCA was done and showed a 17 out of 30, which is clearly abnormal for somebody who is 41 and has a PhD. So she wasn't functioning well at home. She tried to go back to work, but wasn't able, and so she's been on disability since then because she was just unable to go back to what she was doing before. So I guess I included this case because it illustrates the value of the post-stroke functional assessment and how you may not be able to detect these problems, and the patient was not really aware of them either. And so this is why this screening evaluation with post-stroke functional assessment can be so incredibly valuable for patients. So in summary, we still have a lot of gaps in our rehabilitation and understanding of recovery for language and cognitive deficits in stroke patients. There is a lot of research going on for Alzheimer's disease, and the group here at Wake Forest is using intranasal insulin to improve cognition for patients with mild cognitive impairment and early Alzheimer's. And piggybacking on that concept, I have a study of intranasal insulin and post-stroke cognition for ischemic stroke patients, but we're also including hemorrhagic strokes. We're looking at patients over the age of 40. We're looking at a time frame of 6 weeks to 6 months after stroke, and we're randomizing eligible participants to intranasal insulin versus saline, and we're treating them for 3 weeks. We do cognitive testing at baseline after the 3-week treatment, and then after another 3-week washout period. And then again, we're looking at blood biomarkers and DNA, and we're making sure patients don't get hypoglycemic, although we know that that's actually not going to be an issue. So this is an American Heart Association funded pilot study that we're trying to wrap up in the next couple of months here. So just wanted to let everybody know, if you have patients that might be interested, feel free to send them our way. So to recap, cognitive deficits affect a significant number of stroke survivors. The evaluation can be done with a post-stroke functional assessment, can be done at discharge, can be done at the clinic visit. But either way, if you decide to do more formal testing, the MoCA is a really great screening tool. It's got excellent predictive value for future cognition and physical function. Neuropsych testing can be helpful for establishing a diagnosis of whether the problems are from the stroke or from dementia, and it can be helpful for disability. And then work and driving evaluations are both challenging, but I recommend a personalized approach to that because it all depends on the patient and the job and their social support at home in order to develop a really good plan going forward.